confirm this is the case that you saw before? This is your lung case?
Yes, it is.
Can you tell me about your assessment of this patient, please?
So for preoperative assessment, I would like to visit the patient on the ward, and before speaking to the patient, I would review his medical records to gather a history of past medical history, any relevant anaesthetic documentation in the notes, including any previous difficulties, and also would review his investigations, in particular his blood tests, and also our main concern would be his preoperative pulmonary function tests and his imaging as well.
Right, so you're particularly interested in his preoperative lung function test. What can you tell me about those?
Well, the preoperative lung function tests that we've got here were fairly recent. So I'd have a look at the FEV1 and also the FVC to grade how severe the obstructive lung disease is that he has. And it would allow us to calculate what his predicted post-op lung function would be like after his lung resection.
Right, so where would you grade him?
So this patient's FEV1 is about 70% predicted, and his FVC around about 70% predicted as well. Sorry, his FVC around about 2 litres, which is reasonable. Anything less than about 800 mils to a litre would indicate he may be high risk for post-op ventilation.
Right, and you said you were going to predict after the operation as well. Can you explain a bit more about that?
So yes, you'd speak to the surgeon to discover how many lung segments the surgeon was planning to remove. And from that you can calculate what the predicted post-op lung function would be based on the fraction of lung being removed multiplied by the preoperative FEV1.
So how many segments have you got?
So there are 19 segments in total.
And if he said he was taking out the left lung?
So that's 9 segments out of the 19, so it would be your pre-op function, FEV1 multiplied by the fraction to calculate your post-op.
Right. You said pulmonary function test, also imaging. Tell me a bit more about this X-ray.
So first of all, I would check it was correct patient demographics, so that it's interpreting the wrong X-ray. And then the most striking abnormality here is in the left middle lobe. There's a rounded opacity. There doesn't appear to be any traction or scarring around that. There doesn't appear to be any loss of volume. An additional abnormality that you can see is probably quite a large gastric bubble, but you can't see evidence of the hiatus hernia, which was mentioned in the history.
Yes, it was, wasn't it? Right, so you said you'd look at all these tests and then you go and see this patient. What are you going to look for in the history, particularly when you're talking to him?
So the patient's got a history of COPD, so I'd want to take a history from the patient about the severity of the patient's symptoms, what his exercise capacity is like, and which symptom, whether he gets any cardiac symptoms, which would suggest sort of pulmonary hypertension and secondary cardiac impairment. So what he's able to do day to day, whether he gets orthopnea or PND, any ankle swelling, and also whether he has any symptoms of chest pain, palpitations, which would need investigation. And
what sort of tests would you look for to do to find out his exercise capacity?
So if CPEX testing is available, that is one very good, reliable, non-invasive. It's a cardiopulmonary exercise testing. The patient's hooked up to a 12-lead monitor, ECG monitoring, arterial saturation monitoring, and have a pneumotachograph and gas analyzer attached to a breathing mask. And then have a graded exercise regime where the end result is a 9-plot graph, which is then interpreted to calculate the patient's anaerobic threshold.
Right. What happens if you haven't got that available or your time is short?
If you don't have that available, there are sort of other tests that you can do, such as the 6-minute walk test or shuttle tests and climbing flights of stairs. Tends not to be done nowadays, but is available still. And a distance of about 400 metres is set as the gold standard as being a marker of a lower risk for post-op dyspnea.
Right. Okay, so you've seen this gentleman, you've had it reviewed all the tests and you've got some CPEX testing. Anything else you want to know preoperatively?
So you'd like to know a little bit about medication history, smoking history. I think there was a history of a hiatus hernia documented, so you'd like to ask the patient any symptoms of reflux that may be relevant for the induction of anaesthesia.
What about type of cancer? Would that be of interest to you?
Yes, small cell lung cancers in particular are linked to something called Eaton-Lambert syndrome, which is relevant for thinking about neuromuscular blocking agents and whether you'd need to think about post-op invasive ventilation.
Right. And other ways cancer might affect the anaesthetic?
Well, the patient may be, I think this patient is on quite high dose steroids, so you'd need to think about steroid cover, and also may put them at high risk for poor wound healing and things like that. This is a lung cancer as well, so you may have some distal areas of lung which have got mucus retention and may be prone to chest infection post-op.
Okay. This candidate showed a good knowledge and highlighted the areas of particular concern in this case. She also knew pertinent investigations and had a good overall view of the case. She was successful in this oral, with each examiner giving her a score of 2.